and how these insulins can be utilized for inpatient hyperglycemia management. The other topic for today is obesity. So obesity is increasing unabated and it has reached epidemic proportions globally and in India. So what are the new pharmacotherapy options we have for obesity management? We will be discussing it. We have a team of very experienced and senior endocrinologists with us who will be sharing their rich wealth of experience with us. So I once again welcome you all and I hope that it will be an enjoyable and a fruitful learning session for all of us. So I invite the first speaker for today, Dr. Shafi Kuche sir. Sir is a senior consultant in Division of Endocrinology and Diabetes at MEDANTA, the MedCity. Sir has a keen interest in non-alcoholic fatty liver disease in patients with diabetes. Sir has done extensive research in the field of fatty liver disease, role of newer anti-diabetic drugs in fatty liver disease, inpatient glucose management. Sir has several publications to his credit, and the latest and the most prominent being the E-LIFT trial, the D-LIFT trial. These all trials have been published in international journals of repute. Sir is an associate editor in for diabetes and metabolic syndrome, clinical research and reviews, also reviewer for Lancet Diabetes and Endocrinology, Liver International. Sir has been an invited speaker for several international and national conferences. So I once again welcome Dr. Shafi Kuche sir. Sir will be discussing about the role of basal insulin in inpatient hyperglycemia management. Over to sir.
Thank you, Dr. Rujul, for nice words. I will share my presentation. Is this visible?
Yes, sir, it is
Am
visible.
I audible?
Yes, sir.
Okay. Good evening, everybody. Today, my presentation is about role of basal insulins in the hospitalized patients. So I will there is a difference between critical care glycemic control and non-critical care glycemic control. Critical care, we always give insulin infusion. So I will not discuss that. I will discuss about non-critical care setting, glycemic goals, and basal insulins. So basal bolus insulin regimen is the standard of care. We sometimes use oral glycemics, but in general, the standard of care is basal bolus insulin, in which we give multiple doses, usually 3 of rapid-acting boluses and 1 long-acting basal insulin. So we have the ADA guidelines suggest that the fasting and pre-meal glucose should be less than 140, and post-meal or random should be less than 180 milligram per deciliter. And we have to avoid hypoglycemia. We know that for community dwelling patients, the hypoglycemia we should avoid less than 70. In hospitalized patients, we should not go below 80, and preferably we should keep above 100. That is the lower limit. So target glucose range is 80 to 180, and the best is between 100 to 180. So basal insulin, it's very important to understand that is the key component of any basal bolus regimen, because the 50% of your daily dose in the non-critical care setup is of basal insulin, and another 50% is of boluses. So now we will discuss about various basal insulins that are there present in the world and in India, and what are the ideal ones that we should use, and what are their advantages. So basal insulin is available in India. The oldest one is NPH. It is there for more than 50 years now. The various brands available in India are these. The second one was Detamir, which is slightly longer acting than NPH, and it has a appreciable peak, and but it is not, its duration doesn't extend to 24 hours. Then glargine U100, which is now almost the standard of care for, as basal insulin. Various brands available in India are given. And glargine U300, which is the concentrated one, and its duration of action extends 24 hours. And similarly, degludec U100. These last two, glargine U300 and degludec U100, they are the ultra long acting basal insulins, which have improved the management of glycemia, especially in hospitalized patients. So we'll discuss these. What are the studies available of all these 5 basal insulins, and what are their advantages? So the first study that, for when there was only NPH was used, there was no comparison. So that was the only option. The problem with NPH is that it has an appreciable peak that gives rise to increased incidence of hypoglycemia, and its duration of action doesn't extend to 24 hours. So you have to give it 2 times daily. So these are 2 insulin injections you have to give, and then you have to give boluses almost 3 times. Then number of injections increase if you use NPH. And when detemir came, then immediately it was compared with NPH if detemir is, if its profile is favorable or not. So in the first study, detemir once daily was given as basal and aspart before meals. NPH was given 2 times, and regular insulin was given also 2 times. So NPH was given separately. Both insulins improved glycemia similarly. So you can say unit wise, all insulins are same. But hypoglycemia, 33% patients with detemir and 25% patients with NPH had at least 1 episode of hypoglycemia, which in this study was defined as less than 60 milligram per deciliter during the hospital stay. So in this study, the outcome was that they are almost same. Detemir was not, it was not improved version than the NPH in hospitalized patients. So it may be different in community dwelling patients. Remember, this is a hospitalized setup, study. So here it was not different. Then came glargine U100, and immediately it was compared with NPH. So in this study, glargine U100 was given once daily, and glulicine was given as rapid insulin before meals. NPH twice daily, and regular insulin before meals. So the usual NPH 2 times. Glycemic control improved similarly in both groups, again proving that unit-wise all insulins are same. Prevalence of hypoglycemia less than 70 milligram per deciliter, 35% glargine and 38% with NPH. What was most important in this study, that severe hypoglycemia that we fear in hospitalized patients, nobody should get severe hypoglycemia. 7.6% patients developed severe hypoglycemia with glargine, while it was 25% with NPH. So clearly more with NPH. So after this study, NPH became that glargine became the standard of care, and NPH again you have to give it 2 times. Glargine you have to give once only. So this was again one advantage. And then glargine in another study was compared with NPH as a premixed. You know that NPH comes with regular insulin as 30/70 or 50/50. In this study, they used premixed insulin 30/70 2 times, and that basal bolus. And in this study, you can see that trial was stopped early because 64% patients in the NPH regular premixed insulin developed hypoglycemia compared to 24% patients in the glargine. So that is why after that, it was the general consensus that NPH insulin should not be used in hospitalized patients for control of glycemia. So after that, because in NPH group in the previous study, the more patients develop severe hypoglycemia, you have to give 2 doses daily, and premix isn't good. There are more, chances of hypoglycemia. After that, glargine U100 became the standard of care for inpatient management of hyperglycemia. You should understand that you may have seen that sometimes an NPH is given as only 1 dose in the community patients. There it is different, because there it may work, 1 dose may work, because those patients are also on oral hypoglycemic agents. In hospitalized patients, we do not use oral hypoglycemics generally. So here you have to give NPH twice if you want to give it. So NPH as a premix regimen cannot be used, while the analog can be used, but that premix should not be used. If you want to use NPH, use separate NPH 2 times, and where analog availability and affordability are issues. So then this was glargine U100, because now it was the standard of care. Then we had 2 ultra long acting analogs, glargine U300 and degludec 100. So immediately after that, the comparison was between glargine U100 and glargine 300. So in this study, the glycemic improvement, the control of glycemia was similar. You can see it from day randomization to day 10. The mean glucose was similar. So all studies showed this, that unit-wise all insulins are same. But here also you can see that with glargine U300, there was 8.7% patients had hypoglycemia, and with glargine U100 it was 9.5, which was not different. But if you see severe hypoglycemia in U300, there was no patient, and in U100 it was 6% patients. It is slightly, you can say it is statistically significant, but not a huge difference. But yeah, if you want to say which one is better, so we can clearly say glargine U300 is better. And after that, glargine U100 was, degludec U100 was compared with glargine U100, because we have these 2 ultra long actings. One is glargine U300 and now degludec U100. And here you can see again in the graph that from randomization up to day 10 of hospitalization in the non-critical care setting, the improvement in the glycemia was similar between degludec U100 and glargine U100. And there was no difference between the 2 insulins as far as hypoglycemia episodes are concerned. It was 17%. It's a total less than 70, and there was no severe hypoglycemia in this study. And then now we have comparison between glargine U300 with glargine 100 and degludec U100 with glargine 100. Now in our study, we compared the 2 ultra long acting insulins, degludec U100 and glargine U300. And we did this study in patients who underwent coronary artery bypass grafting. We took 239 patients and did randomization on the second day of post-operative day, when there was transition from insulin infusion to subcutaneous insulin. And then it was, followed for 14 days till this stitches were removed. And that insulin adjustment was done to maintain fasting below 140 and pre-meal below 180, same that we have the goals that ADA suggested. And this was the outcome of our study, that from randomization to day 12, the glycemic improvement was similar, rapid, and you can see similar. There was some difference, while degludec 100 was slightly better, controlling from day 1 to 3, but it didn't make any, there was no huge difference here. So we can say for our practical purposes that the rapid and persistent glycemic control with degludec U100 and glargine U300 is similar. And this is the pre-breakfast, lunch, pre-dinner, and 3 a.m. glucose. We measured 3 a.m. glucose in all patients. And you can see there is some, better fasting control with degludec 100. Otherwise, for pre-lunch and pre-dinner was similar between among the two insulins. And this is important that mean daily blood glucose with degludec was 157 and with glargine 300 was 162, which is not different. It is almost because the clinical outcomes doesn't change with this. So it is same. It is not very significant. Here you can see mean percentage of blood glucose readings between 70 to 180, which is the usual range, target range. It was also similar, 74% and 72% with glargine 300. 72% blood glucose readings were in this range, 70 to 180. But one important finding was, which was different, which was in favor of degludec U100, that mean percentage of blood glucose readings between 70 to 140 was better with degludec 100, and between 100 to 140, which is an ideal fasting and pre-meal glucose in the hospitalized patients, it was better controlled with degludec U100, 37% versus 34%. Whether this makes any clinical difference, it makes immediate difference. We can see that degludec U100, when used as a basal in basal bolus regimen, it gives better control. Whether this gives any clinical outcome, it improves clinical outcome, is not known. And in this study, hypoglycemia less than 70, 16% patients with degludec versus 23% with glargine U300. This was not statistically significant. And you can see severe hypoglycemia less than 54. It was only 1 or 2 episodes in each. You can 1.6% in degludec and 4. So overall, we have seen from last 2-3 studies that is done with ultra long acting insulins that the severe hypoglycemia, whether it is less than 54 or less than 40, is very uncommon. So key message: all basal insulins are effective for controlling glycemia in hospitalized patients. NPH as a premixed regimen must not be used in hospitalized patients. If you want to use NPH, you can use, you have to be more careful, and you use it separate NPH 2 doses. Ultra long acting basal insulins are as effective as glargine U100 for hospital management of hyperglycemia. Insulin degludec U100 and glargine U300 are equally effective. Hypoglycemia are less frequent with these newer ones. Degludec U100 and glargine U300 can safely be adjusted daily in hospitalized patients. Thank you. Questions are welcome.
Thank you, sir, for an excellent presentation, clearly highlighting about the role of basal insulin in inpatient hyperglycemia management. We will take up all the queries at the time of panel discussion.
Okay.
So now I invite Dr. Sunil Mishra, sir. Sir is Senior Director at Division Endocrinology and Diabetology at MEDANTA. So sir will be discussing about the generation of basal insulin, specifically in the light of CGM data. So I invite sir.
My slides are visible, Dr. Ujjwal?
Yes, sir, they are visible.
Okay, okay. And now it is in full screen mode as well?
Yes, sir.
Right. Okay. Thank you. Just allow me to minimize this window. So, good evening, everyone. So I will be comparing something different, which Dr. Shafi spoke about. So more about the oral, this newer insulin in OPD care, not oral, but in OPD care rather than in IPD care, and then comparing the use of the second generation basal insulin with technology like continuous glucose monitoring, and in light of the in-range results. So Yeah. So I will presenting this discussion among the following head. One is the clinical implication of the glycemic variability and time in range, and the second in range studies in the recent evidence regarding the TIR in type 1 diabetes. Now coming to the clinical implication one. So why do we need to do the HbA1c? Why do we need to do the glucose monitoring tool beyond HbA1c? So HbA1c we do because it gives us a 3 to 4 months average glycemic control. And as we know, the most of the studies regarding the long-term complications are related to HbA1c. Therefore, HbA1c is the gold standard for the long-term glycemic control. But now we have come to 20 years down the line from UKPDS, and here we are at the stage where despite a glycemic control, we do come across complications. And we have also learned that there are some areas where HbA1c may not give you the true nature of the glycemic control. So the glucose monitoring is required to recognize hypoglycemia. There may be the ethnic and the racial difference in the HbA1c because of the hemoglobinopathies, and some hemoglobin variant may be different into different races. Even in India, we have had such situation, people visiting from northeast have hemoglobin E variant, and that gives a false result in HbA1c. If you want to do a personalized diabetes management, so you need to do frequent glucose monitoring, and then inter and intra-assay glycemic excursion, inter and intra-day glycemic excursion cannot be seen by HbA1c. Hemoglobinopathy, anemia, and pregnancy I talked about. Sorry, excuse me. And adjustment that adjust the treatment regime when level are elevated. So HbA1c may not give you the immediate level of the glycemia, but you have to do the continuous glucose monitoring or frequent glucose monitoring regarding that. So beyond HbA1c, glycemic variability and time in range are the key metrics. So now we are a little ahead of the time from previous years, previous decades, where we look for the glycemic control by glycemic variability, glycemic excursion, time in range, percentage in the time person spent in a good glycemic zone. So glycemic variability is the common challenge in people with diabetes. As you can see in this slide, the amplitude of the glucose going above the target range is determined by the glycemic variability. You may be wondering many a time, you are treating a person for diabetes for years together, and then one fine day person will come with a complication like in retina or in nephropathy. What has happened? My patient is having HbA1c below 7. So probably because those glycemic excursion were not recorded by the usual day-to-day monitoring, and because of those extreme glycemic excursion, person might have had complication into the different organ, including retinopathy. And we do witness such cases now and then. And then there are international guidelines recommending the time in range and glycemic variability as a key metric to facilitate effective diabetes management. So how far we are in terms of the time in range, in terms of the long-term complications. So of course, time in range will give you the immediate glycemic control target, but is it related to long-term complications? So there are limited studies, but the studies which are available right now, including one prospective study from China, and then DCCT retrospective analysis of the number of the glucose values available, and they translate it into the time in range profile as per the current standardization standards. So what we know that in people with the type 1 diabetes, both retinopathy and microalbuminuria are significantly low by tune of the 64% and 40%. And in terms of the neuropathy, it's 25% low in type 2 diabetes and CKD. Mortality is also less with people in time in range. So you will ask, at what level of time in range, what drop in time in range from the when the time above range, the glucose is dropping. So it's approximately a 10% drop in time in range associated with the increased frequency of decline in those complications. Number one. The second thing is that it is not only a 10% drop. The second thing, when you compare the two CGM value, what you have to see, the frequency change in the time below range and time above range. Sometimes those value changes more, and that may not be reflected only in the TIR value. So international guide now recommends that the time in range and the glycemic variability are key metrics to facilitate effective glucose control. And now since 2022, every year the annual diabetes American Diabetes Association annual standard of medical care has also recommended that A1C may not provide you measure of the glycemic variability or hypoglycemia. Therefore, time in range is associated with the better risk of the microvascular complication, can be used assessment of the glycemic control. So we should be familiar with this phenomena. So glucose fluctuation are processed in time and two principal dimension. One is the amplitude and time. So it means how soon the glucose is going up. Like whenever any person take food, what we tell two things. One is the glycemic load, and second is the glycemic excursion that is happening, the glucose load and the glycemic index and glycemic load. So if the glycemic index of the food is high, so that means the amplitude is quickly going up. So quickly, like in this excursion, you say glucose was low in the night at 3 a.m., but in the morning the glucose goes up and crosses well above 180. And second thing is the load, means the area under curve. So for how long the glucose remains high or low in particular level. So that gives you the time person spend into the bad glycemia or euglycemia or hyperglycemia. So these things should be remembered. So glycemic variability is the assessment of the amplitude. So the excursion going up and down is the amplitude of the glucose excursion projected along the y-axis, and this process is metric by metrics as standard deviation and percentage of the coefficient of the variation or the mean amplitude of the glucose excursion, or what we call MAGE. And this glycemic variability usually should be below 35, some people say 33 or 36% in for various different type of the diabetes, and also depends upon the agent we are using. So then time in range, I will come later and I will speak about, sorry, some issue. Oh, don't know. Yeah, sorry. So, right. So I was here. So understanding time in range target for type 1 and type 2 diabetes patients. So now we understand that we need to have a good time in range. So what should be that time in range? So that means the people spending a time in good glycemic control is important. So I give an example. So suppose if you are driving from Gurgaon to Delhi and there is 50-kilometer distance, you reach there in 1 hour. But it never occurs that your car is driving every time the 50 kilometer per hour. Sometimes you may be as low as 10 or 20, or sometimes you may be as high as 70 and 80. So the variability as well as the speed reaching there is all this phenomena of time in range, glucose variability. So suppose if you are driving very slow and very fast, so obviously the variability is high. So the risk of accident will be more. Similarly, if you drive in a standard pace like 40 to 50 kilometer per hour, so you are driving more safely. And same thing happens for the glucose excursion as well. So for example, this patient, the ambulatory glucose profile AGP is done over 24-hour period. The blood glucose are measured. The lower limit is kept at 70 because below 70 the hypoglycemia is defined, and above limit is 180, the post-meal glucose is kept. So time in range in type 1 and type 2 diabetes is defined as you see the green bar part, the green bar gives you the time in range. So 70% of the time people should spend their glucose in this zone. So 70% of the time should spend within this target zone. If we come for the time above range, it should be below 25%. It has a 2 level. First level is up to, say, up to 250, 25%, and above 250, again, below 5% should be there. When it comes to the below level, so up to 74%, and below 54, it should be 1%. So it depends upon 5% can be below 70, and 25% can be below above 180 to define a time in range in type 1 diabetes. So coming again, the target range, if we are dealing with people who are older and high risk of type 1 diabetes and type 2 diabetes, so people where you don't want to control very strictly, so you may define the target differently. So you keep 70 to 180, but this time the time in range will be 50%, and time above range up to 180 to 250 will be 80%, and above 250 will be 10%. And also you don't want to control glucose very tightly, so you will keep time below range is less than 1%. So these TIR changes depending upon the type of patient you are treating, and this is what we call as individualization of the treatment. So coming to the insulin, like second generation basal insulin, glargine U300 and degludec 100 has been studied in different cohort in type 1 and type 2 diabetes patient, and they are compared with in different studies regarding real randomized control trial and the real world studies, and the study which Dr. Shafi talked about for in-hospital glycemic control. So I will be talking about in-range study. This is the latest one where glargine 300 on insulin degludec 100 was compared. So it's a recent evidence in time in range in type 1 diabetic patients. So time in range using glargine 300 versus insulin degludec in type 1 diabetes. This is head-to-head randomized control trial, and this was done from Italy. And this is 12-week multi-centered randomized active control parallel group open label studies. People who were enrolled in this group were 18 to 70 year of age of type 1 diabetic patients. And you can see here there was insulin titration phase of 8 weeks followed by a blended phase of CGM or of 20 days was used. And this is open label studies both with the glargine 100 as well as the degludec 100 12-week period, and primary endpoint was measured at 12 weeks. So what it tells us about that primary endpoint was that percentage time in range above 70 to below 180. That means usual 70 to 180 at 12 weeks. And secondary endpoint was the total CV at 12 weeks as a measure of the glycemic variability. These are the baseline characteristics. As you see here, the mean age was around 43 years, and rest of all parameters were comparable. HbA1c at inclusion was around 8% on most of the subjects, 60% of the subjects, and duration of diabetes was also around 10 years. So baseline characteristics are these, and the complications were equally distributed, a different group, both retinopathy, nephropathy, and neuropathy were equally distributed among both the group. So what the results are, at the end of the 12 week, there is non-inferiority between the two second generation basal insulin in terms of the endpoint glucose value TIR between 70 to 180. Both arms, as you can see, glargine 300 versus degludec 100 were similar. So non-inferior in terms of the endpoint in terms of the time in range. So both were able to achieve time in range in a similar fashion. So non-inferiority of glargine 300 versus degludec in terms of the time in range. Secondary endpoint was the glucose variability. Again, there was non-inferiority at 12 weeks. As you can see, the secondary endpoint glucose variability at 12 weeks was similar in both the groups between the glargine 300 and degludec 100, and it has met the endpoints. The non-inferiority of glargine 300 versus degludec demonstrated in terms of the glucose variability. Other secondary endpoint like HbA1c were similarly decreased in both arms at the end of the study, 7.38 and 7.51 between degludec 100 and glargine 300, and it was not statistically significantly different. When switching from first generation basal insulin, these patients were on first generation basal insulin, appropriate glycemic control was observed in both the treatment group, and without any significant difference in terms of glycemic variability and time in range, and as well as in HbA1c. So hypoglycemia profiling was assessed from the CGM data, And as you can see, anytime hypoglycemia, severe nocturnal or daytime hypoglycemia were not different. And also the level of hypoglycemia below 70 up to 54 or below 54 were no different between, and also in terms of the incidence as the event were not different. Nocturnal hypoglycemia was again assessed between the two second generation basal insulin, and it didn't demonstrate any trend towards the increased nocturnal hypoglycemia either between the two different insulin group. Right. So within day-to-day glucose variability at 12 weeks was similar, and using this clinically relevant blinded CGM matrix in range study show that glargine 300 and degludec 100 provide a comparable glycemic control in terms of within day and in between day glucose variability in people with type 1 diabetes. So in range studies, the first randomized control trial comparing the second generation basal insulin analog, glargine 300 in type 1 diabetes using TIR as a primary endpoint, and primary endpoint were met, non-inferiority for glycemic control. So time in range, of course, two insulin should be same, but the secondary endpoint is probably more important. When you are achieving the same time in range, how much glucose variability particular insulin is giving. So it was non-inferior, both are same. And the most important finally is that to achieve that similar glucose level time in range, how much hypoglycemia we are experiencing while using the two different insulin, similar occurrence of the hypoglycemia with no unexpected safety findings. So therefore, friends, glargine 300 is non-inferior to degludec 100 in people with type 1 diabetes in terms of the glycemic control, that is time in range, and in terms of the glycemic variability, and no difference in occurrence of hypoglycemia or safety profile. So the takeaway is that the CGM allows more complete assessment of the overall glycemic control, supports time in range, 70 to 180 as a treatment target. At present, there is no CGM literature to use to compare the second generation basal insulin, and this is one of the time in range with the first randomized control trial, and it has demonstrated that the non-inferiority of glargine 300 to degludec 100 in terms of the time in range. So it achieved its endpoint, and with that, thank you very much. Back to Dr. Razul.
Thank you, sir, for an excellent deliberation on a very novel topic, that is use of CGM matrix in the comparison of second generation basal insulin. So now I invite Dr. Jasjeet Singh Vasir, sir. Sir is Director, Division of Endocrinology and Diabetology at MEDANTA, Gurugram. Sir has a keen interest in obesity management. So sir will be discussing the newer treatment options in obesity management. Over to sir.
Thanks, Rujul. Dear friends and colleagues, a very warm good evening to all of you, and thanks for all of you to join in the second part of the clinical update. So this topic is as fresh as it can be, and it's freshly baked. So you are very likely to hear and experience a lot of new things or first times in the next about 15 minutes. And that's why I've branded my talk as new. Almost every slide while preparing either taught me something new or I learned something new. And I hope in the next 15 minutes, I share all of my learnings on the new therapy options for obesity. So this is how the flow of the talk is going to go. We all understand that non-communicable diseases, including obesity, hypertension, diabetes, etc., are a major contributor to loss of life, which is quantity of life, and disability, which is quality of life. So these two major aspects of an individual's a population, global health parameters are majorly affected with these non-communicable diseases. In reality, in today's date, an interesting fact, while going through the literature, the term BMI was coined in 1972. So it's taken those many years for us to now start offering therapy for obesity. It's been a long journey, and now more and more since we have therapy options beyond just diet and physical activity, and at the other extreme is bariatric surgery. The pharmacotherapy has made us adopt understand, evaluate, and treat obesity in a much greater way. And as you see here, with the context of our population, the growth of obesity, we all know the reasons for increasing in the non-communicable diseases, a socio-demographic, economic, environmental change in the behaviors of the entire population. And again, numbers of increasing obesity prevalence. The important fact about obesity is you have 100 people diagnosed with obesity. We go to the extreme right part of the slide, where less than 1% of these patients are offered a proper structured therapy for obesity, not just limited for a patient with diabetes coming to you and sensitizing them or telling them that, oh, you have a weight issue, you need to take care of that. So that at the present, that's where we stand. But this is now changing and has changed to a large extent thanks to the evolution of pharmacotherapy, what I would be discussing today. So the importance of weight loss is clearly defined in this slide, where from the left you have a 0 to 5%, to the right we have a 15% weight loss. Now you see that red line which I've drawn on this shows an incremental benefit of increasing weight loss. Let's take the example of diabetes, which all of us see very commonly. At a 0 to 5%, so about 2 to 3% weight loss, you'll find some betterment in hyperglycemia. You go in the range of up to 10%, you can prevent diabetes. But then on the extreme right, if you have to help somebody achieve remission of diabetes, the amount of weight loss is about 15%. So clear cut. And in the whole slide, you see as the weight loss keeps on increasing, the health benefits of obesity keep on increasing. Very well understanding that obesity has an association with over 226 health complications coming in the metabolic, mechanical, mental, and monetary domains, which we won't talk about today. So coming to the main part of today's discussion, the pillars for obesity care are nutrition, stamina, physical activity, behavioral change. See, everything we do is a part of a behavior, whether it's eating, what I like to eat, what you like to eat, why we like certain things, is more of an advanced understanding. But that is one of the core areas in which we work on while treating obesity. Till recently, we just had a few drugs, and in our country, we just have Orlistat available, which is approved. The other drug approved is semaglutide 2.4 injectable, currently not available for clinical use. Now, pharmacotherapy, which all patients qualify for being advised pharmacotherapy, is very important, though the number of points here is very less. Let's look at the first point: have tried a lifestyle but cannot reach healthy weight. We must understand this very important word. It's not ideal weight, it's healthy weight, where weight loss is equated to achieving health benefits of the 4M things which I talked about in the last slide. Secondly, virtually all weight loss strategies lead to a plateau and then gradual weight regain. We may discuss if anybody wants to know why it happens. Pharmacotherapy comes here. And then you can initiate pharmacotherapy in somebody who's at a certain BMI range and has multiple comorbidities like prediabetes, diabetes, hypertension, etc. So in a summary, this is where kind of a refresher's guide of understanding where to place pharmacotherapy in the treatment of obesity. So this we've already talked about. Orlistat is the only drug available till now. This slide is a busy slide. I won't explain this, but I've simplified this slide in the next one, in which right at the top, you have behavioral changes, including diet, physical activity, IBT, which is intensive behavioral therapy, and the currently available drugs. So this, when you combine all of these in a very structured, intensive way, you may be able to achieve or help a patient achieve or maintain a weight loss maybe in the range of 7% to 10%, not more. Understanding the health benefits are happening or increase with greater weight loss. If somebody requires much greater weight loss, till recently, the surgical options would provide weight loss in excess of 15%, which is known that more than 15% chances of remission of diabetes are very high. It is likely to have an effect on cardiovascular mortality. But obviously, not all patients qualify for surgery, and even lesser number of patients are accept surgery as an option for weight loss. So this treatment gap had existed for these many years, and it's the last decade or so that we are filling up this gap, and that's exactly what I'm going to be talking about. So another new word or a term which I would like to share with you is nutrient stimulated hormone based treatments, which you may call it as NUSH, and GLP-1 based therapy is a part of it. The name itself is self-explanatory that the nutrient goes in and it stimulates and produces a certain hormone physiologically. Now, pharmacologically, we use this to benefit in weight management, and we've been using these group of drugs for diabetes care along with the benefit of weight loss for a pretty long time. So first in this group, which I'm going to be talking about is semaglutide 2.4 milligram. We'll very briefly go through the clinical trial program without going in the details of them, just understanding that how there's been a paradigm change in the way we would be treating obesity in the very near future. And at present also we are doing it. Semaglutide, this is the chemical structure change, which it maintains about 94% homologous to the human GLP. So you give this drug, it's not going to induce an immune reaction. And by virtue of these changes and this fatty acid chain, it makes the half-life of this 1 week. So given once a week, the main mechanism of action acts through the brain, where it not just acts in the hypothalamus. There have been elegant studies done to show even in the hindbrain, it has benefits. And clinically, they come as reduced appetite, the cravings, and improved executive control of eating. That's the core area how semaglutide works. This is the trial program. All we need to understand is the weeks of exposure and these numbers here. I'll go briefly through them. Irrespective of the clinical population studied, like step 1 just had weight management with the baseline weights written here. Step 3 had weight management and IBT and so on and so forth. We see here in the gray bars as compared to placebo, the drug is achieving a significantly large percentage. The magic number in our minds is 15%. We don't need to remember these, but if I total up all of these numbers, you get a percentage in excess of 15%. So it is satisfying what we started off with, the health benefits we would like to provide our patients. The average categorical weight loss, easy to understand here, that almost all the patients on this drug are achieving a more than 5% weight loss. But what is more important, that weight loss in tune or similar to that achieved with bariatric surgery is being achieved in a large percentage of patients. So nearing 30% plus, or like in the step 4 trial, about 40% of these patients were achieving was in tune to that of bariatric surgery. Automatically, the health benefits are getting multiplied and magnified by this amount of weight loss. Not just here, the usual graphs of weight loss go down like this, they plateau, and they go up here. So weight regain is one of the biggest deterrent of subsequent efforts. And you see in this 2-year, the step 5 trial, 104 weeks, continuing the drug for long, leads to stability and prevents gain of weight, which is expected to happen once any therapy, be it diet, physical activity, even bariatric surgery, though the steep fall is there, but the regain happens. So, one area for which there were not many answers, everybody could help in losing weight to some degree, but maintaining weight used to be a big problem. And the other place where pharmacotherapy, the newer drugs are going to have a major impact is in weight maintenance as per the step 5 trial. So not only is it helping in weight loss, these are primarily approved in our country, the oral formulation, because of its benefit, a durable A1C reduction, reduction in the blood pressure, improvement of the lipid profile, and surrogate markers of inflammation like CRP are benefited. So a whole lot of a basket of benefits coming along with the weight loss benefit of semaglutide 2.4. So whenever we practice pediatric medicine, we understand BMI has its own limitations. So to quantify a person's risk, we do a whole lot of other anthropometry, including waist circumference, a surrogate marker of abdominal obesity, visceral adiposity, easily measured. So reduction in waist circumference, possibly, if you look at clinical studies in talking about benefits of reduction in waist circumference and risk reduction, the relationship is much greater than just with BMI because of the limitations of BMI. So we see with across the step trials, wherever waist circumference was studied, there was a very large reduction in the waist circumference. You can take it as a surrogate marker for reduction in the visceral adiposity, about 8.3 centimeters, 9.2 centimeters in step 5 trials. So very clearly, reduction in BMI, absolute reduction in weight, reduction in waist circumference, a surrogate marker of abdominal obesity or visceral adiposity. So the step 1 trial also did a DEXA body composition. And again, like expected, the whole weight goes down. There is a significant reduction in the fat percentage, the fat mass. However, we have seen in clinical practice when there is a total weight loss, the lean mass also reduces. Interestingly, for this, I have no answer, but the clinical data coming from the step 1 trial indicated an increase in the lean body mass, which to me, the explanation I can give readily is that these people were indulging in exercise and were on a significantly good high protein diet. That's the only way we can actually increase the lean body mass despite losing weight. Because if you're not exercising, you're not having a high protein diet, and you enter into a weight loss program, you would expect the lean body mass to go down. So the explanation with semaglutide, according to me, should be a good diet and regular exercise, including resistance training. And that's how this has gone up and the fat mass has gone down. I talked about waist circumference as a surrogate for abdominal visceral adiposity. Well, in the step 6 trial, the visceral fat area and the percentage were also evaluated, and see the significant reduction in the visceral fat area and about a 40% reduction in the percentage from baseline. This is really significant. And if we were to follow up these people who maintain their weight and lost this much amount of fat area for maybe 10 years or 20 years, we'll get the real answer about its impact on the cardiovascular health and overall health, their quality of life indices, their quantity of life indices. However, we just have to uh, extrapolate this data into future prevention of complications of obesity. I talked about surrogate markers of cardiovascular and other metabolic risk factors being significantly improved with semaglutide, reduction in blood pressure, CRP, triglyceride reduced. Safety profile is like with all the GLP-1 RAs. no significant difference. And over a period of time, be it nausea, diarrhea. Diarrhea is one thing which may persist, vomiting and all reduce over a period of time. And in fact, in clinical practice, those who get significant diarrhea may not be able to tolerate GLP-1 ever. So coming to the next progress in the NUSH treatments for obesity, this has been the trajectory, and you see after this how steep the curve for drug developments, and it holds true in diabetes, in all non-communicable diseases. Last about 2 decades has seen a revolution in any and every kind of non-communicable disease, including obesity, diabetes, etc. So the next drug I'll just be briefly talking about is cagrisema. Cagrilinotide is a long-acting amylin analog. Now, amylin is co-produced from the beta cells along with insulin. Again, the nutrient-based hormone, it comes in that very category. It's also produced in the central nervous system. It acts peripherally and centrally with actions similar to that of semaglutide. So a combination is called as cagrisema, which has 2.4 milligrams of both the drugs. And the reason for adding them together is to increase the weight loss efficacy without majorly increasing the side effects, which are primarily driven by semaglutide. So the amylin analog may not really contribute to the increased side effects associated with semaglutide. So makes it a logical combination. This is the phase 1 data. Uh, I had the opportunity of being at the Obesity Week just in November, and these were data which were presented there. So you see here, cagrisema at the maximum dose of 2.4 per 2.4 is now achieving a significant weight loss, which is again like the 30% of patients on semaglutide. This combination, more number of patients are achieving bariatric range of weight loss in excess of 15%. This is the future program for cagrisema, the Redefine 1, Redefine 2 trials. We await their completion in the coming few years. The next blockbuster in obesity and diabetes care is a dual GLP-1 GIP agonist, tirzepatide. Now, I was looking at this molecule and this slide, and I was wondering, hats off to the biochemist or the people in pharmacology to come up with this one molecule, which basically has a dual personality. It takes care of the GLP-1 and the GIP. That to me is again a great thing for whoever came up with this combination and made it work for good clinical care. This is the clinical trial program, the SURMOUNT trials, the 1, 2, 3, 4, etc. And these are the patient populations in which it is going to be tried or has been tried. Just a very brief about this combination. Now see, with each passing slide, you're seeing new data, freshly baked data, which is recent. This is 2022. Now the weight loss is reaching more than 20% in most of the patients. The average weight loss in this trial was about 24 kgs, which is like 52 pounds, and nearly 40% of the participants lost more than 25% of their body weight. So with each new drug, our, at least my excitement about how well we can deliver the care of obesity management is just increasing. So this is the cartoon of how the drug developments and the possible completions of their trials. Of very important relevance is the OASIS, is the phase 3 trial of oral semaglutide in as a weight loss drug. In this, 50 milligrams is being tried with placebo. We expect the trial to get over in the first half of this year. So again, very excited about the results of this trial. Just one last slide about these new drugs. So we've always talked about weight loss, fat loss, visceral adiposity reduction. But one area where less people talk about and even less people work on that is muscle health. So this monoclonal antibody, which blocks activin type 2 receptors, is shown the infusion over every 4 weeks for 48 weeks, not just leads to a more than 20% fat loss, there is a gain in the lean mass. So I was very funnily thinking that, for people who want to lose weight, don't want to get onto a diet and don't want to exercise, this seems to be a good option. Don't take it as advice, but this is where we are going. So the next frontier is going to be helping people lose kilograms, help percentage body fat, reduction in adiposity inside, outside, and helping them gain lean mass, which is good muscle health. I'm sure that is really going to escalate the level of health we can provide to our patients with weight reduction. So this initial slide, which we talked about the treatment gap, is now more or less full of these nutrient stimulated hormone based therapies, including the GLP-1s, the combinations, the monoclonal antibodies, and several other drugs which are coming up. And lesser number of people would actually require to go on to bariatric surgery. These drugs are safe, they're effective, and very importantly, durable over long-term usage in giving the desired results we require whenever we treat obesity. So with this, I thank all of you for your kind attention. I hope you all learned a lot, because I did learn a lot while preparing these slides. So this is your captain signing off. Hope this presentation paves the way for better obesity care that we all deliver for our patients. Thank you very much.
Thank you, sir, for such a nice presentation, giving us an eye opener about the utility of pharmacotherapy for obesity management and for specifically sensitizing us towards a new term, NUSH. So now I invite all our esteemed speakers for the panel discussion. So I would like to start with Dr. Mishra, sir. Sir, you highlighted about the utility of CGM metrics in comparison of generation 2 basal insulin. So does the CGM metrics validates the utility of second generation basal insulin in real world settings as well?
I think so, because there are two aspects, Dr. Ruzul. One is that our day-to-day clinical practice and experience over last 3-4 years with the frequently using the second generation basal insulin has helped us in understanding that the second generation basal insulin are different. We are getting a better glycemic control, better morning fasting glucose value, less risk of nocturnal hypoglycemia. And secondly, I have couple of patients with a type 1 diabetes who are getting a frequent nocturnal hypoglycemia, while shifting them to second generation basal insulin has really helped them. The third point is that the glucose variability now, these FGM is frequently being used by the people in day-to-day practice, and this thing was little or much less used a few years back. Now with those glucometrics we can assess that how the glycemic control has improved. Today we have very short memory again. So today only I had a type 1 diabetic individual who came to me because of the frequent hypoglycemia around 2 weeks back. So I put this person on the second generation basal insulin glargine 300 along with the rapid acting insulin 3 times in a day. And he came, and now looking at his day-to-day glucose variability and day-to-day glucose profiling, it is very clear that where the glucose are increasing, where glucose are decreasing, and now in last 3-4 days his glucose values are much stable. few occurrence of the hypoglycemia, but those are much less, and patient is comfortable. He can change his diet. He can bridge healthy snack in between. So those are the things which people are learning from the CGM. Also, many a time you might have had patients who change their diet pattern just based on these CGM value and the glucose excursion they are experiencing after a particular kind of the meal. So yes, in real day-to-day life, day-to-day practice, it is changing the way we looked into few numbers at the end of probably 3 months or 6 months, whenever we were at the mercy of the patient to show us the data. So now we can at least introspect into glucose value in a much better fashion. Yeah.
Yeah, thank you, sir, for sharing your rich clinical experience. I think it will motivate us all in increasing the use of CGM in our day-to-day practice. So I would like to ask Dr. Shafi, sir, overall, what are the advantages of the usage of second generation basal insulin in inpatient hyperglycemia management?
Yeah. So as I showed you all the studies, in the early studies when NPH and Detamir and we are compared with Glargine 100, which is the standard of care. So there were more hypoglycemic events. Now with these ultra long acting basal insulins, particularly the severe hypoglycemias less than 54 and less than 40, there was no patient who developed severe hypoglycemia less than 40. This was not the case previously. So one area in which I see a huge changes that we don't see now severe hypoglycemias in patient care, which is very important because the mortality are in the outcomes are different if your patient is developing severe hypoglycemia in the hospital setting. So this is very important. Second is the day-to-day variability, which we also applied in our study, the CGM, and it showed that the in range, the target in range and below range and above range, all were very close to the recommendations that ADA suggests. So this is possible only with these ultra long acting insulins and newer insulins. It was not case with previous, particularly with NPH or earlier insulins.
Yeah, definitely, sir. You clearly highlighted the advantages of second generation basal insulin in inpatient hyperglycemia management. So I would like to ask Dr. Vasir, sir. Sir, I would like you to share your personal experience with the usage of pharmacotherapy in obesity management.
Okay, that's a tough one. It'll take me 1 or 2 sessions to complete that. But first of all, I need to congratulate Shafi on the study he did. It's an elegant thing, and I want to thank Dr. Sunil, because that thing on traveling from Gurgaon to Delhi and as an explanation to glycemic variability is so beautiful. And I would like, I always pick up these things. These are very helpful tools in patient communication. You may say glycemic variability is thinking, yaar, kya bol rahe ho tum? So these things are very well appreciated, and I always love hearing these things. So thanks to Sunil for that. So coming to your question about pharmacotherapy. So see, it's very dismal. We only have Orlistat approved. If you talk about DCGI or whichever authority approves these drugs. So our usage of GLP-1 has primarily been focused on label or label usage of these drugs in diabetic patients, where in between our whole group at Medanta, we have the largest legacy of publications on GLP-1, starting from exenatide to liraglutide to dulaglutide. We have a series of publications till now, and I'm sure very soon we'll see about semaglutide, about short-term, long-term usage in diabetic patients with the benefit on weight loss. So as far as experience is concerned, I think our center, all of us put together, would have the largest experience with GLP-1 based therapies. Now, going beyond that, as a personal experience, I'm definitely my usage of drugs for weight loss is pretty good, and it's very important to understand why we need pharmacotherapy, not just weight loss. We have to be sensitive about the struggle about somebody who wants to lose weight and is not being able to lose weight. Going to a physician and being told, "Kam khana khao aur zyada exercise karo," is the usual thing we look at obesity as. And that's the mindset with patients who come to us. So working with them to create clinical results requires a team effort. It is not a one man. It is a team which is led by a bariatric physician. There has to be a nutritionist. There has to be a fitness coach. And wherever the allowance is, a behavioral therapist. These four people put together will reduce the requirement of bariatric surgery by 90%. That I'm very sure of. And in that pharmacotherapy, as I presented, and the step 5 trial, no other trial should need to be done in the future, clearly told us you stop at 72 weeks, the weight will again come back. You continue the drug for durable maintenance of weight, and that is the success. So if you have all the four pillars of obesity ongoing, then you definitely are looking at much better health outcomes of our patients with obesity. I think I'll just stop here. Otherwise, it'll go on to tomorrow.
Thank you, sir, for sharing your invaluable clinical experience. So I would go back to Sunil Mishra, sir. Sir, we have clearly seen the advantages of second generation basal insulin. So according to you, should they be used as a standard of care with respect to basal insulin in diabetes management?
I'm sorry. I have to unmute myself. So probably answer is yes. So first thing is that whenever we use a new drug, we use in the patient where the maximum benefit has shown. So initial studies have shown that the glycemic variability is less, hypoglycemia risk is less. So we started using in the people with type 1 diabetes or people with type 2 diabetes with more risk of hypoglycemia. The second generation basal insulin, when studied and compared with two glargine 300 and degludec in bright study, showed that during titration phase, there was less hypoglycemia with glargine 300. So that further encourages you to start with a little higher dose of the basal insulin rather than titrating patient, because if you look from the study like landmark study, this was a retrospective analysis, it showed that the maximum dose of basal insulin glargine was only 18 units. And then of course, when the 18 units and patient experiencing some hypoglycemia, they will not further titrate the insulin dose. So the further thing about the second generation basal insulin, whether it is glargine 300 or degludec 100, can be given any time of day, and there is also some flexibility time between these insulin compared to the first generation basal insulin. So that allows you to either give in the morning, either give in the evening. Sometimes, especially elderly who are dependent on the children and the caregivers, so they like to get it the insulin done in the morning rather than waiting for night for them to have the meal or to go to sleep. So it is pretty easy, and then giving the long-acting insulin in the morning helps better and more comfortable to adjust according to the fasting glucose, rather than you have to give in the night, and for if you have hypoglycemia in the morning, person will wait throughout the day in a fear of hypo and hyperglycemia. So these are the few clinical virtues we have learned that the second generation basal insulin. I do use it more often now, the second generation basal insulin, as initiating insulin, and also which Dr. Shafi's study and with the study done in our department shows that we are more comfortable with second generation basal insulin. So just to give it a little bit perspective, we've been thinking about using a second generation basal insulin in hospital care for quite long, but we were not able to step into it because we thought that the second generation basal insulin will take longer time for the dose stability, steady state. but probably the studies shows us that it is not the case we were thinking about. Thank you. Yeah.
Yeah, thank you. I would invite sir for also giving.
So there's nothing to add what Dr. Sunil said, but for the young participants who just started their practice, if you really want to get a clinical feel of the second generation basal insulins, choose the patients who come with glycemic variability, recurrent hypoglycemias. That's a really good way to feel exactly where the maximum clinical benefit of second generation basal insulin comes.
Right, sir. So I would like to ask Dr. Shafi, sir. So there has always been a concern that how frequently the dose should be titrated with basal insulin, specifically with ultra long basal insulin, considering that they take 2 to 3 days to achieve a steady state. So I would like to know.
Yeah, as the till now we were using glargine U100 as standard of care basal, which has half-life of 12 hours and the duration of action of 24 hours. So it was considered the ideal one because for 24 hours you can, change daily, adjust dose, especially in inpatient hospitalized patients. And then when glargine U300 came and then degludec 100, glargine U300 has duration of action of 36 hours and degludec has more than 42 hours. So initially they were not used in the hospitalized patients because it was feared that in hospital we don't have 3 days or 4 days as we do in community dwelling patients. We adjust basal after 3 days or after 4 days. There it is okay, but in patients, in hospitalized patients, we have no 3 or 4 days. We have to adjust daily because of the glycemic control. We have to keep glucose control strictly in particular range. So in all the three studies that have been done, including our one, the adjustment was done daily, and we do not find any accumulation of insulin which is reflected by hypoglycemias. There was almost no severe hypoglycemias with all the three studies, even though we adjust daily. So it indicates that there is no problem with daily adjustment of this ultra long acting insulins in the hospitalized patients. In community, there is not the problem. You can adjust after 3 days, after 4 days. There you have the liberty, but it is safe to adjust daily.
Yeah, thank you, sir, for debusting an important myth that we can clearly titrate on a daily basis, even with ultra long acting insulins. So I would like to ask Dr. Vaseer, sir. Sir, is there any criteria that when we should deem that a pharmacotherapy has not worked for a patient with obesity?
So that's a super question. Reason being, if I have to give this answer, I would project what we call as a waterfall plot. So waterfall plot, if you have 1,000 patients, their clinical data is put on the x-axis or y-axis with the clinical outcome you study. So with each and every drug, and specifically so with obesity management pharmacotherapy, there is a major heterogeneity in the responses to the drugs. So let's just talk about GLP-1 RAs, just a clinical pearl of based on our experience over last about decade and a half, would be that 80% of the patients respond pretty well. And in that also there is a graded response. 5 to 7% are non-responders. And if you look at the waterfall plots of these drugs, you will find a similar number, about 5 to 7 to 10%. They don't lose weight and in fact gain weight for whatever reason. But most people in excess of 80% would lose weight. And the average number is given with each drug. For example, you talk about SGLT2 inhibitors, you'll find a 3 to 5 kgs. With GLP-1 RAs, it may go on to double digits. And with the dual GLP-1 GIP, you find numbers reaching about 20 kgs or more, about 25%. There is another category of patients which I call as super responders. They're about 8 to 10%, maybe more towards the 8%. They keep on losing weight. And these super responders are observed with metformin also. You have this group of patients who come to you on just metformin. They keep on losing weight. So this really tells us more about the heterogeneity in the response. You take SGLT2 inhibitors, you find similar responses with a small percentage, again, like 5% or 7%, keep on losing weight, but they not just lose weight, they lose a lot of muscle mass. So the same thing applies in GLP-1s. About 10% would have a very significant weight loss, like we saw in the STEP trial data, about in excess of 30% are losing more than 20% weight. So I hope that answers your question.
Yeah, thank you, sir. So I think all the queries from the audience also, it has been already answered by our panelists. So now I invite Dr. Parjeet ma'am to give her final comments and vote of thanks.
Thank you, Dr. Rujul. I would like to thank all the speakers for their excellent talks and sharing their clinical experience. I think what we had discussed today and what we discuss always in the meetings is the very clinically relevant topics, which are very much pertinent to the day-to-day practice, be it use of basal insulins, the second generation basal insulins in OPD patients based upon CGMS, or be it use of these second generation insulins in hospital, or the management of obesity, as Dr. Jasdeep rightly said, is just not diet and exercise, needs a holistic approach, and pharmacotherapy plays a big role in this. So definitely, I'm sure with that so much of data, what we have at our center, a lot of clinical experience and a lot of studies going on. I hope we are able to justify these kind of meetings and able to share our own clinical experience and share the knowledge as well. And I would definitely want to thank audience for their kind attention. Do we have any audience questions, Rujul?
Ma'am, all the questions, they have been already covered up.
Covered by that. That's very
Yes.
nice. So thank you very much once again. And we would definitely want to continue these meetings in future, and we would want to be connected with you in future as well. Thank you.
Thank you. Good night. Thank you, everyone.
Good night.